All right, so let's get back into it. Last time we spoke, we left, or I spoke, we left off on slide 52, and we just finished with this about analytics. Now we have the vasodilators. Basically, what they do, they cause a vasodilation, so they open up the vasculature to help increase blood flow. First, we have hydralazine. The kinetics there, don't worry about it. That just FYI, this is FYI, just that there's some fast and slow metabolizers there, acetylators. Mechanism of action, it's a vasodilator, take home point. So what does it do? It relaxes the vasculature of smooth muscles of the arterioles. So that's take home point there. It can cause reflex tachycardia and increase renin secretion. So can be kind of counterproductive as far as, so it'll cause a vasodilation, but then it causes increased risk, increased heart rate, and then increased blood pressure, right? So it maybe need to get in combination with something like a beta blocker, which we already talked about, or a centrally acting sympatholytic. As far as its uses are concerned, it can be used for heart failure, usually in combination. It is considered an off-label use. And then it has a FDA approved or labeled use for hypertension, for moderate to severe hypertension, quote unquote. But please note that the JNC 8, which are the most recent guidelines, do not recommend this for the initial treatment of hypertension because they consider there's safer, kind of more effective alternatives out there. So usually, second, third line or whatever, it just kind of depends on the patient. It's also considered to be an appropriate choice for patients that are over 65 years of age, and especially if they have a history of syncope, because this medication can make the syncope worse. And that's coming from the Beers criteria, that list of drugs I believe I've told you guys about, that for drugs to avoid in geriatric population. I did note too, it is safe in pregnancy, or again, relative to like ACE inhibitors and stuff, as some of these other ones. So again, maybe part of its use, or maybe see it there, but again, not real popular, not widely used. And again, JNC 8 does not recommend it as first line. Adverse effects here, you can go ahead and add hypotension to this, just because that is something that that may occur that's not on here. The other one too that's kind of unique and kind of one that people don't necessarily think about is the drug-induced lupus-like syndrome. So this may happen. It's more likely with higher doses, but it can happen with anybody who's on this. And the good news is usually the signs and symptoms regress, but they sometimes can be residual and be detected many years later. And then if that happens, or if the patient may need to be prescribed long-term treatment with steroids to help deal with that. So that's an interesting one. And this is up to 20%, so something that can happen. The neuritis is another one, peripheral neuritis. So this is like numbness, tingling, and that you can give vitamin B6. So note that if that does happen with your patient, and again, the benefit to risk ratio, right? So if there's more benefit than there are risks, then that could be a reason to then keep them on it. Then you would need to prescribe B6 in combination, vitamin B6, which is pyridoxine. Minoxidil. So this is an interesting one. As far as the kinetics go, just FYI. Mechanism of action, go ahead and read through that. But it is a vasodilator, so that's the take-home point. Uses, hypertension, and then the facilitation of hair growth topically. So this is one that they make a topical preparation and a systemic preparation. The topical one helps with male pattern baldness. And then the systemic one can be used for hypertension. However, it is not recommended for the initial treatment of hypertension, again, by JNC 8. So it's typically not first line treatment. And it is something that should be used in caution. There are some box warnings you have to be worried about. And so you can go ahead and add that to this slide here. But box warnings, there are cardiac effects. So when you give it systemically, it may produce these serious adverse effects. For example, it can exacerbate angina pectoris. And so it's actually only supposed to be reserved for hypertensive patients who do not respond adequately to a maximum therapeutic dose of a diuretic and 2 other antihypertensive agents. So this is, again, maybe not even second line, maybe third line. There's also a box warning for quote unquote appropriate use, and that it should only be administered on close supervision. And then it needs to be prescribed with therapeutic doses of a beta blocker agent at the same time to actually help prevent the tachycardia. So to help with this reflex tachyphylaxis. And then the beta blocker in combination also will help decrease the myocardial workload. So something that, again, lots of reasons here why it shouldn't be used first line. And then the other thing to note too, so not only should it be given with a beta blocker, it usually also be given with diuretic, frequently one that's acting on the ascending limb of the loop of Henle to help prevent fluid accumulation. And then when you first administer it, you have to hospitalize and monitor the patients with malignant hypertension and those already receiving other medications to avoid rapid or large orthostatic decreases in blood pressure. So a lot of different reasons why not to prescribe it first line. Hypertrichosis is another adverse effect, which is abnormal hair growth, right? So that's an abnormal amount of hair, which is part of the reason why then they developed it for male pattern baldness. So like I said, they make a systemic and they make a topical preparation. So I always have students ask about, well, if you're prescribing it topically, are you worried about all these box warnings? So the topical preparation does not have the box warnings that the systemic preparation does. So it is relatively safe, or it's safer. But you still can get some absorption or whatever, so just, it kind of depends. But overall, the topical preparation is a lot more safe. And by the way too, the brand name is Rogaine. So you guys probably have heard of Minoxidil by its brand name, and you can actually get some of that over the counter, right? And so definitely a lot safer and not as dangerous. The main adverse effects, if it is the topical preparation, are going to be dermatological effects. So redness, itchiness, just things that, maybe some hair color changes have been one. But anyways, interesting though too, so it is over the counter and it doesn't get absorbed as much, but the FDA still does warn against people who have heart disease using the topical Rogaine, because you can get some systemic absorption, and then you'll remember, you look at all the adverse effects and stuff. And so anyways, interesting drug. Sodium nitroprusside. We have the kinetics here, just noted. There is a metabolic conversion to cyanide, which we'll get into later, that's related to one of the adverse effects and box warnings. But just FYI here with the kinetics. Mechanism of action. So it releases nitric oxide, which is a vasodilator. So it, again, take home point, it causes vasodilation. Uses. Go ahead and read through these uses here. You'll note it's not first line for just plain old vanilla essential hypertension, right? The other thing too is, one thing on the name of it, it is sometimes just referred to as nitroprusside, so you don't have to worry about when you prescribe it to put sodium nitroprusside. That is technically its name. That's the name I'll use on tests and stuff, but I also just note that it is used, or rather people will just write or say nitroprusside. Adverse effects, so hypotension is one that you have to be worried about. Reflex tachycardia, and the cyanide toxicity, I mentioned that earlier. It's related to box warning. So there's a box warning for hypotension and cyanide toxicity. So those are very serious adverse effects. Go ahead and read through those, and please note that those are box warnings, hypotension, and so they're typically used inpatient, and notice, back on the previous slide, so inpatient, usually with a hypertensive crisis. There's a good reason that they're being used or whatever. And so because of the hypotension, and then cyanide toxicity. And this basically affects the way you dose it and the way you administer it, rather. And then appropriate administration, too, is another box warning to note on that. Calcium channel blockers. These are also known as CCBs. Have a list here. just note too that they make these in some different forms. But in verapamil, they have extended release and long-acting preparations, and they are preferred for chronic use. And these are ones that can be used first line for essential hypertension. So you notice there that they are on the JNC 8. They have some other different uses here. You'll notice too they are related to the, and you will see these again in the antiarrhythmic presentation and lecture. So go ahead and read through all those. Adverse effects. So edema is one. Peripheral edema is one that you have to be worried about. Gingival hyperplasia. So with specifically the ones that end in dipines or dipines. So we have nifedipine and amlodipine especially. And then constipation too is one, especially with verapamil. So those are common adverse effects. Vinoldipan, not common vasodilator, but just go ahead and read through this. It's a dopamine, which is abbreviated DA agonist. Take home point. Severe hypertension. So you read through those niche uses there, but typically inpatient. Now we have the renin angiotensin system inhibitors. First, we have the ACE inhibitors, so abbreviated ACEI. These all end in the pril, right? Very popular drugs. Again, these are first-line treatment for essential hypertension. Kinetics here, don't worry about that. Mechanism of action, please read through all of this and make sure you look at it, but take-home point. And nice for students, I think, is that the classification is also mechanism of action, and for my testing purposes. So what do? They are ACE inhibitors. They block the angiotensin converting enzyme, right? Just note too with mechanism of action, this is part of the reason they think that, or why you can't have cough and angioedema. So those are both adverse effects. Angioedema is a rare but serious one, and the cough it's annoying and people don't like it. It's a dry, unproductive cough. So uses hypertension, like I said, first line for essential hypertension. Also, they are considered renal protective, so they do help protect the kidneys, and so therefore they are typically first line or an agent of choice, so to speak, drug of choice if a person has type 2 diabetes. So please note that. And then I mentioned too, they've helped their kidney protective, so a benefit there. And sometimes heart failure and then post-MI also used. Adverse effect, that dry hacking cough, like I said, non-productive. It's really annoying. And it's something that, you know, can make people not want to take it anymore. The angioedema is a rare but serious adverse effect. The other thing to note too with the angioedema is that their African American patients may be at an increased risk for this adverse effect, and that's actually the only time I've seen it in San Antonio. It was with an African American lady. She was on lisinopril, and it's also, I mean, they said that in the text too. It's not just because of my experience, but so note that is something that, and again, it can be life threatening, can be pretty severe. Luckily for the lady in San Antonio, they were able to discontinue it, and she was in the hospital for a little bit, but she survived, so that was good. So another rare one is the renal function deterioration, which I mentioned that it's renal protective, so I know it seems counterintuitive. It's just one of those things that, again, it's a rare but serious. So for the majority of patients, it is renal protective. But it is one that I wanted to note just because there may be an association with deterioration of renal function and or increase of BUN and serum creatinine. And these are particular in patients that have low renal blood flow. For example, someone has heart failure. So then the guidelines recommend that you should consider discontinuation only in the patients with progressive and or significant deterioration in renal function. So it's something to think about. Hyperkalemia is also something to think about, and you'll note that that's with some of the other antihypertensive medications too. So in combination, I'm sorry, no, those are hypokalemia, but hyperkalemia, like for example, if you're in combination with a potassium sparing diuretic, you have to be worried about that. And some of the risk factors that for hyperkalemia include renal impairment if a person has diabetes, if they're using the potassium-sparing diuretics, like I said, if they're doing any kind of potassium supplements, or if anything any potassium-containing salt. So some of the salt substitutes, the sodium-free salt, they'll put potassium in it too. So anyway, so that's something to think about. Other than that, usually well tolerated. Not a lot of patients have problems with it. Definitely, hypotension is a concern. You have to be thinking about that with any of these. Sometimes dizziness can be a concern. Sometimes that's related to the hypotension, but anyways, that's just some of the more common adverse effects. Contraindication. So definitely put a star by this. Highlight this, etc. Definitely want you guys to remember this. So for the ACE inhibitors and for the ARBs, the ARBs, which we'll talk about a little bit, boxed warning fetal toxicity. So when pregnancy is detected, these need to be discontinued ASAP, as soon as possible, because definitely documented fetal harm. So these cross the placenta and have fetal harm. So definitely note that. Here are the ARBs I just talked about, the angiotensin receptor blockers. These all end in sartan, which maybe help you guys memorize those. Mechanism of action, so take home point, it's an angiotensin receptor blocker. So again, nice categorization, mechanism of action, kind of 2 in 1. Unlike the ACE inhibitors, it doesn't have the bradykinin effect on the metabolism, and so you do not have to be worried about the cough. So if that is a reason why a person wants to discontinue or can no longer take the ACE inhibitors, it can be a rationale and a reason to prescribe an ARB. Uses, you'll notice very similar to the ACE inhibitors, and a lot of times too on the guidelines, so JNC, etc., you'll see where they'll put ACE/ARB, so they're considered to be very similar as far as how they work and then what they're used for. Like I said, one of the big differences to notice is so you don't have to worry about the adverse effect of the cough, so no cough, or the angioedema. These rare, even very, very rare, but still something to think about. Also contraindicated with pregnancy, and also a hyperkalemia. Renin inhibitor. So this is elascarin. Read through kinetics there. Mechanism of action again helps with classification, etc., but it's a direct renin inhibitor is the take-home point. And so here it is, just more spelled or more detailed for you guys. I've had some students in the past that wanted to know more of the specifics. So by all means, please read through that. But for testing purposes, just know that it is a direct renin inhibitor. Use, so treatment in hypertension in combination or as a monotherapy, but please note, and I put it here, it is not recommended for the initial treatment of hypertension, unlike the ARBs and the ACE inhibitors, which are recommended by the JNC8. So that's noteworthy. So a lot of times you see these as an adjunct. It'll be added on later with maybe an ARB. But anyway, so yeah, typically not first line monotherapy. So now we have the drugs used for the treatment of hypertension, urgencies and emergencies. So I will be providing a couple other presentations on this, but go ahead and look at these. Just know that these can be used IV or PO, and that basically you're supposed to, relieve the symptoms within 24 to 48 hours, and then eventually have control over a long term. And then the emergency is a more acute, so urgency versus emergency and so much quicker goals and a much shorter timeline. Summary tables, so these are good. So definitely look at these, look at the classification, adverse effects, contraindications, and as always, if there's a contraindication here that's not on my slides, please still look at it. So please pay attention to this table, put a star by it, it's a great summary table. Same thing here. Again, look at these. Make sure you squint at it and you pay attention to all the details on these tables as well. That's the end of part 2. So thank you all for your time and attention. As always, feel free to email me if you have any questions or you want help finding something or whatever. I will talk to you guys later. Have a good one. Bye.